Good evening, everyone. Thank you for joining our webinar. We are joined by Professor Osama. We kindly waiting for a few more people to join in. We had like 300 registrations, 323 to be exact. So we'll give guys a few more minutes to log in, then hopefully we can start by 7:10. Just a few reminders, the CPD points are going to be sent automatically for those who registered correctly for the Zoom webinar. All your videos and mics have been muted. Kindly address any questions related to the topic in the question and answer section, which will be addressed at the end of the lecture. We thank you once again for gracing us with your presence. Let's give people a few more minutes and then we can begin the lecture shortly. So we thank each and every one of you for joining us. We are joined by Professor Osama. We're still giving people a few more minutes to log in.
Okay.
Thank you once again for joining the KAPD webinars. We encourage each and every one of you to join our association. Remember, it's not only for pediatric dentists, but it's also for general dentists who have an interest in pediatric dentists. It's also open to both undergraduate and postgraduate students who also have an interest in pediatric dentistry. So Prof, the attendees mainly comprise of dentists, pediatric dentists and undergraduate students.
Great.
Yeah, so majority will be from Kenya, but we usually have foreign participants from Egypt, thanks to you, from
Thank you.
Nigeria,
Yeah.
Tanzania, Uganda, Zimbabwe, and South Africa.
This is very good to hear that most of the attendees are from Africa. So that's a great thing.
Yes, your lecture will have a very wide reach. Most of the people you must have met last year in the conference.
Yes,
and
yes.
we are hoping we'll be able to host you once again.
It will be my pleasure. It will be a very good pleasure. So hope things go well so we can move freely.
Yes.
as before.
I think we'll give guys, let's do 3 more minutes and we can begin at 7:10 sharp. Huh?
Okay.
So right now we're at 117 attendees.
123 now. Great. It will be a very good opportunity that the IAPD, not the next time, the one after will be held in South Africa. And I think this will be the first time to hold a big meeting in Africa. Yes.
In fact, I think after that, they've opened the bidding to host the next conference after that.
Yeah. Actually, we were thinking about having something like this, and we are still looking at it.
Yeah, for 2025.
Yes, yes. Egypt can be a very good host to that. Yes.
All right, I think we can begin.
Okay.
So good evening, everyone, ladies and gentlemen. Thank you for gracing us and attending our webinar. We are joined today by Professor Osama El Shahawy, a great friend of our association. He's graced us. He visited us in 2019 and was presented in one of the IAPD regional meetings that KAPD had hosted. He is a renowned professor, having studied in University of Cairo for his undergraduate and master's, with a master's in pediatric dentistry and dental public health. He became an associate professor of Cairo University, as is now a full professor both at Cairo University and Future University in Egypt. He's the current president of the Egyptian Society of Pediatric Dentistry and Children with Special Needs, and also the vice president of the Arabian Academy of Pediatric Dentistry. So Professor Osama, we give you a warm welcome. Karibu sana, and we are looking forward to your lecture on pediatric full mouth rehabilitation treatment planning.
Thank you so much, Dr. Goodshow, and thank you for the kind invitation. And it's my pleasure to be there with the colleagues and friends from Africa. And thanks for the Kenya Association of Pediatric Dentistry for the kind invitation. And again, I'm very happy to share with them my lecture. And as Dr. Goodshow said, it was a great pleasure to me to be there in the beginning of 2019 in the regional meeting of the IAPD, which was held in Nairobi, where we had a very good opportunity to meet colleagues and friends. And actually it was a very nice and well organized meeting. We had a very good science, and we shared a lot of good memories together. And one of the best things that we had the opportunity to visit the Masai Mara area, which to me it was a magnificent experience, and I'm looking forward to go to there again, it's a very nice place to visit. So I chose today to talk about one of the best, to me, subjects that I like to talk about, and it's the treatment planning or the full mouth rehab treatment planning. And why do we say full mouth rehab? Let's talk about the pattern of decay or the pattern of the problem that we face, and mainly in our region, either in the Middle East or if we're talking about Africa, because of the neglect and because of many factors that we all know. Decay is a big problem, especially when it comes to a very young person, the child, who suffers a lot, and his family suffers with him with problems that we can, at a certain point of time, say that it is a kind of handicapping. So we can have a person who can say that he is dentally handicapped, having a wide spread of problems in both arches, in the anteriors and in the posteriors, with pain and infections and so forth. So this is a problem that faces us a lot. So what is our vision to treat these cases? And what are the strategies that we should be bearing in mind when taking a decision to treat this child? It's a complex thing, as we are going to see in a few slides from now. But what I wanted to say is that we have to have the knowledge about everything related to this and take the best decision to this child according to what we have in or on the ground. So we see cases like this, and the question always remains, should we extract all these teeth? If I'm having a child having upper and lower and anterior and posterior with these kind of infections, if I took the decision for a child like this, who is 3 years of age, I will definitely have a full clearance for his mouth. So is this the best treatment alternative for him? Let's imagine, what is he gonna eat on, or how will he be able to talk or smile or whatever of the functions that we are having our teeth for. So it's a real problem. Reviewing, and now social media makes a lot to us, and sometimes it's positive, sometimes it's negative, but I'm referring to some of the social media statements now, just to tell you something, that in each area of the world, there are some special things that should be taken into consideration. So if I'm treating a child with the same features and the same problems, if I'm treating him in Africa, maybe the treatment option is different if I'm treating him in North America, and maybe different if I'm treating him in Europe, in spite he is the same person. Why is that? Because we have a lot of variations, and that's the purpose of the presentation today. So let's see together. So this was one of the comments, or actually 2 comments that were there when one of our colleagues who is practicing in India posted one case of treating a severely mutilated anterior teeth, as the case you were looking at in the previous slide. So briefing what they say that if you try to save these teeth, so you are looking at a heroic action, or you're trying to be a hero, but beware, because trying to be a hero may bring you to zero very quickly. So our colleague here, who's practicing in the States, was objecting on having this extensive treatment, which our colleague in India was using zirconia crown and so forth, and it was done under general anesthesia. So he was claiming that this will be a very expensive treatment, and if it failed, you will be having a very serious problem. And the other colleague was saying that the best thing he will do is to pick his forceps and extract these teeth. So do we agree on that? Do we agree on just pulling out teeth and removing everything and that's it, in spite of having this as a treatment alternative? Let's see. So again, if we attempted to extract a tooth, especially the anterior teeth, it will solve the problem if you're having infection, if you're having pain, whatever of the problems that are there, it will be relieved by just extracting this tooth. But how about thinking of that this extraction will deprive this patient from the benefit that God made these teeth for? So we should reconsider the idea of extraction as a magical solution. One of the other concepts that I also wanted to talk about before going into more details, and again back to the social media, and this case was posted in the Pediatric Dentistry Forum, where our colleague here posted this case where he opened this first primary molar and second primary molar, and that's what he found. Either we agree or disagree with what he did, but what he did here is that he restored these two primary molars, which, as we can see, has two surfaces, an occlusal and distal. Actually, in the first primary molar here, we can see a buccal extension. What he did is that he placed glass ionomer, which can be technically seen as a good restoration, according to what we can evaluate here. But the question remains, do we agree with him with this treatment planning or not? And how do we evaluate if this was the best thing? From which point? From the point of, did we do a proper pulp treatment or pulp preservation? If we're talking about indirect pulp capping here, is the process of doing an indirect pulp capping with placing a restorative material, which has its pros and cons in terms of strength and in terms of longevity of the treatment, and in this deep case of deeply seated decay after being removed, so we again did indirect pulp capping, plus putting this restoration in a stress-bearing area, because this restoration is a proximal restoration or a two surfaces restoration. What is the age of the child? What are the years left in function? So these are all questions that should be answered before taking a decision to do like our colleague did. So let's have a quick look on the responses. So someone said that there is still an obvious decay left behind, and he advised him to do better for his skills. The other one questioned, why didn't you look after putting a crown, which is again something, a very good view, because we are not looking at the tooth itself, we are looking about the whole oral cavity, and that's what I meant. So when we are talking about the whole oral cavity, and again, looking at the depth of the decay, we should consider coverage in such a case. And again, we will see more now. This was one of my very first cases using the, what we say, aesthetic crowns. I had this case with this amount of decay. The patient was 3 years of age with this amount of destruction, slight anterior open bite, and again, what is our treatment planning when we see a case like this? Should we extract all these teeth? The anteriors, we have the canines affected, and definitely the molars, and everything is affected. What I proposed at that time when I had the pre-veneered stainless steel crowns, we did a full mouth rehab using these crowns, and this was the immediate post-operative and we have been following it up along the years, and this is the follow-up. It's worth to see that the gingiva is always swollen. It's getting better along the follow-up, but it's not in the best thing because this child is a mouth breather with the anterior open bite, as we said. And another feature that the preveneal stainless steel crown didn't behave the best with the gingiva as the zirconia is doing, as we will see in other cases. But again, for this child, we managed to keep her, she was a girl, we managed to keep her having a healthy teeth and in function along the years till came the time of shedding. So did we do right? Was the decision on this a right decision or not? Actually, if we managed to keep her with her teeth in function till the time she changes her teeth to the permanent ones, I think we did her better. And we kept following her up later, just to have here one good notice. You can see some of the crowns are still there. This is a 6 years follow-up, as we can see, and there is one of the premolars coming out. So what we can say here, if we focused on the lower permanent anteriors, we will find proximal decay happening in them. And in the bottom picture, you will see that the first permanent molar also started to be decayed. So in this case, we have a very high activity. This child, since the beginning, is a very high actively having decay and very high risk. So the best treatment alternative in such cases is full coverage, as we have done. And treatment or no treatment, actually, when we see it in 6 years later, we will admit that the treatment was a very good option to the child because we were able to preserve everything and pass this time till the time of shedding and coming up of the new teeth. And now we'll be struggling to solve the problem of the high risk in the same child, but in the permanent teeth. So let's go into details. How can I take a decision for a child like this? When since we started to have the options, so what is the best for each child? So this is a case, 3 years old girl. She is uncooperative from a high social level, and this is important, and let's see why. And our question is, what is your treatment alternatives to the right central incisor, upper right central incisor for this child? So if we had the possibility of having an open discussion, we would have a lot of thoughts, but I will summarize that now because this is a tricky question. Why is that? Because this tooth is an anterior tooth and having decay mesial and distal, which will pop up in our minds that it can be restored with an adhesive restoration. And this is the first option that we can, that will come up to our minds. But before going into details, am I thinking about this tooth as a single tooth or a tooth that is in an oral cavity having this amount of decay that we can see? We have the lower incisors affected, we have all the canines and the molars. So the question remains, am I treating this tooth by itself or am I treating a tooth in an extensively affected oral cavity? This is a very important thing to build up on. So what are our alternatives? Should I use SDF, the silver diamine fluoride, which emerged in the last 5 years as a very good alternative in treating these cases? Should I do smart restoration, which is the silver modified atraumatic restorative treatment, which is using the silver diamine fluoride and then putting composite or glass ionomer to cover it up with? Or should we use our regular best friend, which is the composite, using the celluloid crown form or building it up, resin modified glass ionomer of any formula, and finally the zirconia crown. So each of these, we will go with it and see what will help us better to achieve our point. So what are our options in terms of options if you're talking? The options are treatment or no treatment. You may say no treatment is an option. Yes, no treatment sometimes is an option in some countries and some cultures. Actually, in some developed countries, they say that no treatment for a case like this is the best option. And definitely there is a financial background lying behind this treatment option, because a child like this will, if the government is supporting the treatment, so he will go to the theater and it will cost money to put him under general anesthesia and to do this extensive treatment. So sometimes no treatment is advised, and they say that it will serve what it serves, and if anything went wrong, we should extract, which I totally disagree with. How about the treatment itself? The treatment is extraction, the classical, easiest way with its easiness and, as I've said, debilitation or destruction of everything of the functions that we have. Or we can think about arrest. And arrest, the biggest thing that does arrest as we're talking is the silver diamine fluoride. So it stops the decay, but it does not preserve or regain the function and aesthetics. It's just an easy way by just dropping this silver diamine fluoride on the tooth, which is again excellent in effect, but it does not regain the function or aesthetics. And definitely we can use fluoride and we can use sealants, or a more advanced thing, which is, or more advanced category, which is called the atraumatic seal, as the atraumatic restorative treatment, which, as we all know, is based on just removing the decay, gross removal of the decay with an excavator and placing a resin modified glass ionomer or glass ionomer on it. So it's an atraumatic restorative treatment, or the smart restoration, which is a mixture between the atraumatic restorative treatment and silver diamine fluoride. And one of the best options and the best evidence-based options, which is called the Hall technique, which is extensively reviewed with research, and actually it is a very good technique, which is based on placing a stainless steel crown with no preparation, minimal invasion, no preparation at all, and just sticking this stainless steel crown with a glass ionomer on a decayed tooth without drilling and without making any intervention in the tooth, based on the fact that the arrest can come when you seal. So seal is very important. So if I was able to seal the tooth, so no nutrients are coming to the tooth again, I will stop the progress of the decay, and then the stainless steel crown is one of our classical and very good options, and the child can use it properly. And the comprehensive treatment, which is the last category of options, and I like to name it risk-based restoration. Just to remember always that we have to respect the risk. No way to survive with any treatment without respecting the risk. And it starts in this category from the least, which is the infiltration or the resin infiltration, according to the how initial is the decay. And the second option is the filling, which is our classical treatment modality. And finally, the full coverage. So these are the treatment options that we have: either treatment, or no treatment. So let's see what is our treatment decisions based on. When I'm thinking in a treatment decision option to rehab a case with this severe problems, I will have to look at the evidence. So evidence now means quality literature that tells me what is the best options available now, again backed up with good research. So I have to review this frequently and see what is the latest on that. And then we have another determinant on the decision-taking process, which is the dentist preference, my preference. And we will have a look now, what is the preference of the dentist? So back to the evidence, we have to respect the risk assessment, as I was saying, and we have to look at arresting the progress of the decay, and definitely we have to look in the literature for the best restorative material to fit this case, and we will see now some examples, to have a long-term success to the point that I don't want to repeat this treatment again for this young child. Okay, so how about our preference in the treatment? Me as a dentist, I want something that is easy to apply, and I definitely want it to be reliable, not to have any problems. As our colleague was saying, you don't want to be a hero and come back to zero and then you are criticized. So you want reliability. Definitely, we will have to look at the cost. What is the patient's need? Either the child himself or his parents. Definitely they are looking about proper aesthetics, function. Definitely they don't want pain and no failure is anticipated or needed. Nothing is failure free, but again, what we want, we don't want failure, and should be, or better be easy, and the cost is a very important aspect as well. So now we are taking a decision for the tooth that we were talking about. So again, we have to look at the evidence in the literature for these items. We have to see what can I give this child, because again, me as a dentist, if I heard about the zirconia crowns, for example, as a very good alternative, but I was not well trained on it, or I didn't have enough time to just do the preparation properly and handle it properly. So this is a problem, and I will be faced with the fact that I will not be able to provide this solution or service, and this is a problem. So sometimes it's important to provide this service, but I was not trained on that properly, so I'm not providing the service. So this is very important to take into consideration. And the last thing is the patient needs. So for example, the cost. If I'm providing this service, just like the zirconia crowns, and the cost is too much for the child, so, or for the parent, so this will be an obstacle providing this proper treatment. So let's review the risk-based comprehensive restorative treatment, as I like to name it. In this case, we are treating a young child. So what are the implications when I'm talking about a young age patient? We will definitely anticipate low cooperation level, especially that I'm working on talking rehab. We are talking about anywhere between 15 to 20 teeth that should be treated. So low cooperation level should be respected. And we need, because he is young and we still have this teeth in function for at least for the anteriors 4 or 5 years, and for the posteriors we're talking about 7 to 10 to 8 years. So we need really to restore functional aesthetics for him, and we need to have a long-term success, which is the 4 years for the anteriors and the 7-8 years for the posteriors. And we don't want to have failures. And we should, and this is very important since we're talking about the risk, we should anticipate that this child, just like the first case that I showed, the child was having a very high risk, and definitely we were imposing on that and take care, but she came 6 years later with the permanent teeth affected. So the compliance for diet and oral hygiene is a problem. And again, I don't want to fail because the patient is not compliant. So if I want to succeed, I have to respect, before starting the treatment, the problem of the compliance. And this is something that we can interview the patient with and know which direction we are going in. Because I may be doing a perfect job, but his compliance will ruin everything. So the overall risk, this is very important to respect. Again, this is the third time I'm saying this, because the high activity oral cavities, which we can simply describe as a burning house, because the high activity, because of the diet attributes, the salivary flow, the salivary pH, and any genetic background, or the bacterial load in this oral cavity makes it a very active oral cavity that can cause more and more problems. So let's have a look on this case for each item of these. So what I'm seeing here is a widespread decay. So this is very important. Again, if I'm treating 1 or 2 teeth that are only affected in an oral cavity, is totally different than treating any of these teeth in an oral cavity with a burning house like this. Also, when I see this, I should be very cautious. What's the demineralization areas which is surrounding these lesions, as you can see in the canine, and it's happening in the first primary molar and the second primary molar. Even if the second primary molar is not really decayed, but I see these patches, so I will anticipate that this child will come back again within maximum a year with a new defect that will be happening in this place in the second primary molar. So this is a note that should be taken into consideration before designing the treatment, especially that this child went to the general anesthesia and I don't want to admit him again. When we look at the pattern of decay per tooth, we will see that there is a multi-surface lesions. When you see this first primary molar, after starting to reduce it to have a crown, you will see that it had proximal, buccal, and in the coming picture, we will see that it was having lingual, so it was a wraparound. We were having decay that is happening proximally, buccally, and lingually. So the best option for a tooth like this is not definitely a restoration with an adhesive restoration. It should be crowned. This should be taken into consideration. Look, the amount of decay, and when I see a complicated occlusal fissure system, as I'm looking at this second primary molar, again, I have to respect it and see that this will end up by further problems unless I covered this tooth. The depth, as we were discussing in the case of our colleague over the Pediatric Dentistry Forum, so the deep cavities, again, should be respected. I will not anticipate a very good success if I chose the indirect pulp capping procedure for the restoration of these deep cavities and using an adhesive restoration or a glass ionomer circumferentially, which is having a cavo surface angle with the remaining tooth structure, which is very big, and I have a very big restoration. So leakage will be anticipated. So if I chose to do indirect pulp capping in a deep cavity with a multi-surface restoration, this will be a failure. because I will anticipate leakage, and leakage will affect my indirect pulp capping, and we will have failure. So again, in a case like this situation, as you see in the same patient, this is the picture of the same patient, I will be advising using the full coverage because it will save the margins of the restoration area, no restoration, so the margins of the teeth will be all protected, and we will be protecting our decision to do indirect pulp capping if we saw that indirect pulp capping is applicable in a case like this. Another thing that should be considered is the tooth-based risk here, location and size of the restoration. So again, in the same patient, we have these two patterns, either on the lateral incisor or the central incisor. And this white lines will give us an idea about the amount of the restoration if I decided to do an adhesive restoration to cover this tooth. So you'll find that it's very big. The amount of restoration will be very big in relation to the remaining tooth structure. And it's an incisor part, so it's a very high stress bearing area. And on the central incisor to the right, we have an angle. So the angle and the amount of restoration will make this tooth and its adhesive restoration liable to fracture and failure. So again, in a case like this, with deep decay and multi-surface problems, full coverage again is a better treatment alternative. How about the bite? One of the most important things that we should be taking into consideration is the canines. Why? The canines are very tricky because they stay very long, just like the molars, and should be staying in function. And if we are having deep decay as this one, and this amount of destruction, I will definitely not be able to survive with an adhesive restoration. Why? Because again, it's the same concept, deep decay and adhesive restoration, we will be having leakage, and the canines are having a very long period to go. And the last thing is that the bite at this corner is inviting to have pressure that is happening on this tooth, and it causes debonding of the big restoration that I decided to do if it was an adhesive restoration. So again, the bite sometimes is a cause of failure because the corner of the mouth is having a very high forces of the occlusion, and in this case, the adhesive restoration is not a successful option. So back again to our case. What do we do if we are talking about the evidence or preference, and if we're talking about the parent preferences? Coming back to this situation. This is the tooth that we were talking about. So if we're talking about choosing SDF as a treatment, according to evidence, the SDF is very good as respecting the risk because it stops the decay and it arrests the progress, but it's not a restoration at the end of the day, so it's not serving as a restoration, so no restoration longevity is anticipated. For the dentist, it's easy and reliable, may be reliable because it stops, but it's not a reliable restoration. And the cost is significantly fine. And for the patient, it does not give good aesthetics and definitely no function. And if we're talking about its reliability and cost, it's again a good thing to stop the progress as we are talking about a child. If we don't have the possibility to admit him to general anesthesia and he's very young and we want just to stop the progress for later, this will serve as a stop of the problem for later. If we talked about the smart restoration again is something good, but if we are talking about, and it's easy for the dentist maybe, and it's sometimes reliable, but as a long-term reliability, the process of doing the smart restoration in the anterior region or even in the posterior region is not very reliable in long term. It can stop the progress, it can arrest, it can solve a problem that is happening now easily, but long term, it's not helping that much. Definitely, you can use the composite and resin modified glass ionomer. These are two very good alternatives that we are using. It gives good results in terms of reliability, but definitely it does not arrest for good because it's not full coverage. So sometimes we anticipate problems that can happen around the restoration margins or leakage. So composite and resin modified glass ionomers are good. They are easy options, more or less. It's not that easy, but more or less, because they are there in each clinic and we are all trained to use them, and we have them as good alternatives, even in the primary teeth or the permanent teeth. So we can rely on using them, but the question remains, did I using them? Did I respect the risk 100%? Did I respect the possibilities of recurrence? Did I respect the possibilities of ruining the successful indirect pulp treatment, which we do prefer nowadays if the tooth is good candidate for indirect pulp treatment, or as the whole technique describes, which is a no removal of decay, just seal and stop the progress. So if I'm looking at this direction, so composite and resin modified glass ionomer are very good options again, but they are not the best when I'm talking about the perfect seal. And the last thing for this tooth, for this anterior tooth, will be the crown. So here, if we are placing a crown, we are respecting everything: the seal, the aesthetics, the gingival integration, the function, and the rest of the progress. So everything except the price, because the zirconia crown is the most expensive of all other options. But as we started in this case, we said it's from a high social level family, so cost was not a problem. So we decided to cover these teeth, and this was the result. We had the opportunity to cover up these teeth with the zirconia crowns, and it doesn't matter if on the posterior teeth we put zirconia or stainless steel, it carries the same concept. But if they wanted to have an aesthetic alternative posteriorly, that's their call. But the most important thing is to admit or to use the full coverage in the anterior region, which is again the best option, is the zirconia crown. So these are the treatment options that we have, and this is the thought about having a full mouth rehab case, and what are the ideas that we should be putting in mind when we have the treatment modality. And now we will go through two cases just to look again. And this is the case by itself. She was called Judy. She reported at the age of 3, and she was having this amount of decay, and we managed to do her some pulp treatment, as you can see, and we placed the crowns, and we have been following her for a long period of time. As we can see on the upper left, that's the beginning of the case, immediate post-operative. And the best thing about the immediate post-operative is you can see that there is no laceration of the gums. And this was always emphasizing that should be taken into consideration when we do preparation, which is very important in placing zirconia crowns. Subgingival preparation is very important. And we can see in the later pictures the progress of the kid till the point that we reached that she shedded the lower central incisors, and we can see the component of growth in the upper jaw. We can see in the last two pictures to the right, we can see that the child managed to live happily with good aesthetics and good function along the years. And the decision of having coverage was a very good decision, because again, this child, when she was coming to the clinic for checkup, she was again very uncooperative, in spite that she knows that she will be only examined, nothing will be done, but she's an extreme uncooperative patient. So that's why having a treatment with no problems in the future is a very good option. Again, the follow-up, she started to shed the upper incisors and now the lower laterals, and everything is going well in a later date as well. Some crowding. However, again, she's living happily. And this is one of the best things that we can see from the zirconia crowns after shedding, because we can see here the margins of the crowns tells us this is without cleaning, without anything, just freshly extracted. And we can see here that the margins are very glossy, because the zirconia crowns does not allow plaque easily to stay there. And the relation of the crown to the gingiva is usually a very good relation. So again, when we see this child passing 3 or 4 years in advance and having these results, we again can say that we did her a good job, rather than thinking about just extracting these teeth or putting adhesive restorations just to fill the mesial and fill the distal and maybe fill some part of the incisal. And she comes back again and again and again and again with problems with lost fillings and problems that we have to solve. And here is she happy. And again, the follow-up. Okay, so this is an underwater picture from the Red Sea here in Egypt. It was shot by one of my friends. He's a dentist and he likes to take underwater photography. It's really magnificent here. Very nice. So this is a technique that can be used to preserve severely mutilated anterior teeth. And I personally have been using that for years now. I can't recall, maybe 15 years. So it's a very reliable and good technique. And it was published, and this was the case that was in the paper. It was a severely mutilated teeth. And as I always say, if anyone said that these teeth should be removed, he's absolutely right, because it is subgingival, extensive decay, high risk, and so on. And if we focused, we will see that there is infection beneath the lateral incisors, 2 swellings. But we managed to use this technique to save these teeth. And it's a very reliable technique. We do the pulp treatment, as you can see, and then we remove 2 to 3 millimeters from the coronal part of the radicular pulp, just to make it clear. And then we inject, and this is the clinical picture after using calcium oxide iodoform mix. Metapex was used in this case, and then we remove part of the radicular pulp, and then we inject a packable glass ionomer of any type, just like Fuji, Kitak, Kenfield rock, whatever material. So part of the material goes in the 2 to 3 millimeters radicular pulp, which is just like a glass ionomer post, and then we extend the rest to the incisal direction, as you can see it this way. And then we start doing the preparation of these teeth, and the preparation should be subgingival and should end on sound tooth structure, as we will see now in a following picture. It will be more clear than this. So we do the preparation subgingivally, and then we start fitting the crown. And in this case, I was using New Smile crowns. So we use the Tryon crowns, which are the pink crowns, just to fit them subgingivally. And then after doing this, we put the final restoration of the crowns, and we cement them with the same material, which is a packable glass ionomer, just to make the final restoration the same, the final, cementation, and the core material the same thing. And here is the crown, and here is a diagram to what is happening, the root canal filling, and then the glass ionomer post inside, and then the crown up on there. And this is the final restoration in the follow-up. You can see the gingiva is nicely placed there, and we had this very good result. And this is another case that shows the technique again in a close-up. So that's the amount of tooth structure that we started with, as you can see it. And then after doing the pulp treatment and putting the glass ionomer, we can see that the tooth looks like enlarged. And then on the third picture, after doing the preparation, you can see how much is now apparent from the tooth structure by itself. So this gives you a confidence about the thorough effect or the amount of the natural tooth which is giving resistance to the final restoration. And it was proven that by this technique, you can have success just like 80%, 86% in the first year and 80% in the second year of follow-up, which is very good. But again, we have to emphasize to the parents that this is not 100% successful treatment. It is a high success treatment, and it's very reliable. But again, if the child had a knockout or a trauma, or he bited on a very hard object, something wrong can happen. But again, it's a very reliable technique that can save this tooth rather than just pulling it out, as you can see it now here. And this is the rest of the steps from the beginning till the end after fixing the crowns over the remaining tooth structure. And here I will end up again with this case. This is another case which reported at the age of 2 years and 4 months, which is very, very, very young with this amount of decay. Again, should we pull out all these or not? We have an abscess related to the upper left first primary molar. Lower anteriors are badly broken down. So what's the solution? Clearance. Is this the solution? We decided to do a full mouth rehab, and this is the anteriors up there. And we did the technique on them. And we did the preparation, the glass ionomer, which I name core and crown technique, glass ionomer core and crown technique. And this is the immediate post-operative after placing the zirconia crown on it. The only problem with this case that we will see what happened with that at this point of time, they didn't release, the company did not release yet the zirconia crowns for the canines. So what we will see here, that we covered the incisors, but we were not able to cover the canines with composite in again a very high risk patient. So that this was a pitfall, but it was not meant to be, but it was because there was no zirconia cuspids at that time. So we kept following up the case. As we can see here, she lost one of the lower incisors, but because she was very uncooperative, she didn't let us stick one for her. But again, what we can see from the upper anteriors that we have a very good gingival integration. The badly broken down anteriors were saved, and we can see that things are going well. She's using her teeth properly, and things are going well. So from the preoperative to the immediate postoperative to 2 years later, she is doing well. And again, at this point of time, they didn't have the zirconia crowns for the molars. It was only for the incisors. What you see here is a pre-veneered stainless steel crowns for the molars. Further follow-up, we can see that the canines in the bottom picture started to lose their composite, as I was mentioning at the beginning, because of the bite and because of a recurrence, because this is a high activity. And in the second picture, you can see that it started to discolor because composite can discolor. And while the zirconia crowns are retaining their color with no discoloration. So this is another thing. Again, pictures of the preoperative, intraoperative, immediate postoperative, and in the follow-up. The bottom right picture, you can see if you looked at the canines, you will see that the canines had more decay. The second primary molar, which wasn't there in the oral cavity at the beginning and it erupted later, became decayed again. Again, this is a high activity oral cavity. So if I respected the risk in the beginning and that I had the zirconia crowns for the cuspid, it would have been a better option to cover them as well as I covered the anteriors, and they had good reliability, had good aesthetics, and no change in color and anything. But since we had a problem in the posteriors and again the canines, so she was admitted for another GA 2.5 years later, where we placed, as you can see, zirconia crowns for the canines just to save them. And we managed also to put another zirconia crown on the second primary molar. And we kept following her up. One of the problems, as we can see in the upper picture, is losing part of the veneer because of the pre-veneered stainless steel crowns. Sometimes by time and function, you may lose part of the veneer. This doesn't happen definitely with the zirconia crowns. And we started to have shedding, normal process happening. And this is the shedded tooth with new teeth coming out. We did our job. We preserved the teeth. We preserved the function. We preserved the aesthetics. We preserved a very good health for this child. Again, versus extraction or versus no treatment or versus placing, as happened with the canines, placing a restoration which will fail or have recurrence with it. And by this, I end my presentation. This is an absolute hour. Thank you so much, and I will be happy to have your questions. And thank you again for the Kenya Association of Pediatric Dentistry for inviting me to present this presentation. Thank you all.
Thank you, Professor Osama. That has been a very delightful and enlightening topic. I think we all now appreciate about the multi-factorial aspect of dental decay, and the fact that you mentioned that that it's a burning house of so many complex factors that determine what will determine your treatment plan. So I think we'll head over to the question and answer section. Kindly address any questions you have in the Q&A section, and we'll begin with the first question. Professor Osama, with regards to full mouth rehabilitation under GA, how long does this take you on average?
This is a very good question as well, and this opens something that I should also declare and make it clear. One of the things that makes this a good option for treatment or not is how long should we put this child under general anesthesia, because as we all heard and maybe read, that sometimes when it's too long, it may affect the brain of these children or their intellectual activities later in the future. So this is something that it's not yet proven 100%, but definitely I should bear in mind when I advise this as a treatment alternative that it should be a factor. So the problem here is how much training did I have just to make these cases, which is an extensive cases with too much treatment, a good alternative to this child. So according to the amount of training, I may finish like what I'm doing, these extensive cases. I usually take around 2 to 2.5 hours, which is not too long and actually not too short to finish these cases. But once I heard in the Pediatric Dentistry Forum, someone who was very proud that he did a case in 9 hours, which is nonsense at all. So it's very important, again, when I advise with this amount of extensive treatment, that I should be able to deliver the treatment in the least possible time, which should not by any means exceed 3 hours, again, in this big cases. So if I'm not well treated on that, I should refer it to someone who can do it in the least possible time, and this is a very important aspect again. Thank you for the question, because this is an important decision-taking boundary. Thank you.
And in your setup in Egypt, is full mouth rehabilitation only accessible in the private sector, or is something that's common in the public sector and maybe in the dental schools for treatment under GA?
Perfect question as well. Actually, it's there in the private sector, definitely. And we also have 2 very good alternatives for that. We have in Cairo University, we have a very big department, general anesthesia department, where all the staff members, the professors and the associate professors can practice doing cases under general anesthesia with a very good subsidized fees. So it's applicable and accessible for many families. For example, in Cairo University, we do on the average, on weekly basis, around 30 to 40 cases. So it's a big number. And again, because it's subsidized, it can be a good alternative. And some of them are free of charge. Also, the other option, which is not private, is our society, the Egyptian Society of Pediatric Dentistry and Children with Special Needs, is providing this service starting from totally free, which is coming from donations, and very subsidized, maybe less sometimes than the Cairo University. And we managed to do that also under general anesthesia, and more, we do it more with the handicapped children coming from poor families. And also staff members are doing that. So answering this question briefly, so it's found in the private sector, and we have also some other universities do the same in the university, and the society is helping on that.
Okay. With reference to deep caries deciduous molars, would you advise then, is it better to do a pulpotomy before placing the crown, or you'd still prefer doing the Holtz technique with smart materials?
Very good question also. And this is a whole presentation, which I'm ready to do anytime if you want. because this is a controversial. Definitely, if we were more conservative doing this, meaning no pulp treatment, in spite, if we're talking formal, if we're talking about indirect pulp capping, it's a type of pulp treatment as well. But in our minds, pulp treatment is pulpotomy or pulpectomy. So if I'm able to preserve the tooth with no pulpotomy, and I just can stop the decay using a crown or doing a seal properly, I'm preserving the normal function, preserving the normal shedding time, because as we all know, sometimes the pulpotomized teeth shed earlier. And I'm preserving also, if we're talking about the time, the first question was talking about the time. If I managed to treat this case with just covering the teeth without having the necessity to do pulpectomy and pulpotomy, I will definitely decrease the overall time of the rehabilitation. So the question remains, when should I do pulpotomy and when should I do indirect pulp capping? Where to go? So that's why I'm saying it's a whole presentation, because it's a long way to go, but I want to summarize this now by saying that if I have the proper diagnostic and expertise to preserve the pulp and not to remove it, because this is a tricky thing, because one of the factors, as we all know, on deciding on that is the pain, which is nothing. If we're talking about a child who is that age, how will I ask him about the pain, or how I ask about the diagnosis is very tough to do. So it needs a lot of experience, and we should all know that sometimes failure is anticipated, which is very, very, it's not that much, but it's sometimes anticipated. But if I managed to do more indirect pulp cappings, it's better for the child than having pulpotomy, just to say that I did the best, just to clear it. I don't want to have failures. So that's the answer of your question.
Could you kindly elaborate again the root filling material you mentioned for primary incisors when you do a pulpectomy?
When we do pulpectomies in primary molars, we look at a material which should be having a good antiseptic effect. It should be filling the root canal properly. It should be easy to go in properly and go to the end of the root canal if this is applicable. And one of the most important things is to have it having a resorption rate which is equivalent or equal to the resorption rate of the tooth. For example, if I used the regular resin modified zinc oxide and eugenol, it does not resorb easily. So sometimes if you place this in a root canal of an anterior tooth, sometimes the tooth itself starts to shed and it gets loose, and you find the zinc oxide eugenol still hanging inside, and sometimes it acts as a foreign body that deviates the permanent from coming out in the proper direction. So the best material, as proven scientifically, is a mixture of calcium hydroxide and iodoform, which comes in the brand name of Vitapex or Metapex, and some other companies do it as well. But again, the main component is calcium hydroxide and iodoform mix. And I used to manipulate this material in a different way to make it more easy to apply. And actually later, I found some research acknowledging this, is by just adding some zinc oxide powder. Again, zinc oxide powder with no eugenol, just the powder, to the paste of this material, the calcium hydroxide iodoform material. So it makes it just like a putty, so you can condense it easily. Or in the anterior teeth, you can just roll it just to look like a gutta-percha, and then you place it inside the root canal and pack it inside. So it does a very good job. So again, it's called a calcium hydroxide and iodoform. The name is Metapix and Vitapix.
You mentioned when doing the build-up for the anterior restorations that you can have a GIC build-up as a core, would be 2 to 3 millimeters. Does this resorb when exfoliating, or does it affect exfoliation?
Yeah, it does not definitely affect the exfoliation. That's why we just put it 2 to 3 millimeters. When the root resorption comes to the point that makes the tooth loose, we may find inside some 2 to 3 millimeters of the root left. So this 2 to 3 millimeters, which is the same 2 to 3 millimeters if I placed a glass fiber post, or the 2 to 3 millimeters if I used any type of posts, intracanal posts that were advised in the literature. So it does not affect the pattern of shedding, because if the resorption reached this point, the tooth will be already loose, just to go out.
And similarly, can one do a composite core and crown instead of using GIC?
Definitely. Composite is an alternative, but the problem with composite that it is technique sensitive, meaning that I'm talking about a root canal that was filled with a root canal filling material, and the area that I'm working in is at the gum margin or sometimes subgingival. And this area, definitely, if I used the adhesive, which is the bonding material that should be placed before placing the composite, I will not be able to guarantee that there is no contamination or seepage or blood or whatever. So why should I use a sensitive material, since I can use a less sensitive material, which is the glass ionomer, and it sets chemically. It does not need any adhesion, or it does not need any sort of curing. So it sets chemically. So that's why the glass ionomer here is superior to putting composite or compomer or whatever that needs a bonding or adhesive.
There's a question about, do you introduce fluoride therapy to the patients, especially those who are high risk? And are there other treatment modalities that you recommend for high risk patients?
Definitely, fluoride is a standard of care that should be provided, since I, again, respect the risk. So if I'm having a risk profile that says that this child is a moderate risk or a high risk, I should integrate fluoride as an important aspect that should be told to the parents and should be repeated every 3 to 4 months. And the best now in my practice and by literature, the best formula is the fluoride varnish, because it's easy to apply, it's very specific, and again, rather than having the gel or foam, which is, it doesn't give the same contact to the tooth surface, because as we all know, the fluoride varnish is sticky and it stays there, so the tooth benefits from it. And again, we can make use of some of the very good formulas, just like the Enamel Pro Varnish of Premier or the Clean Pro of 3M, which also integrate another components with the fluoride. It's not only fluoride varnish, it has calcium and phosphorus integrated with it. So the calcium and phosphorus can work side by side, as we all know, with the fluoride, to repair or do remineralization of the starting lesions. So using the fluoride varnish in the high-risk patients is a very good option. Again, we can repeat it 3 to 4 times a year. Okay.
With reference to the zirconia crowns, I think some of the attendees didn't understand. Most of these are prefabricated crowns. They come as a set. And once you've done your preparation, you maybe try 2 or 3 sizes, and whichever fits the best, then that's what you cement. But the question is, for a full mouth set of zirconia crowns that you have shown, relatively how much is the cost to the patient?
The cost to the patient, well, definitely if you decided to make a zirconia crown service in your clinic, so you will have to have the kit there. But the patient only what matters to the patient is how many crowns that you used for him. For example, if you are putting on the 4 anteriors, you should be putting on the 4 anteriors. So the price of the kit is again variable according to the type. There is the most elite ones are just like New Smiles or maybe the Sprib crowns. Both are American brands. Or there are some less price, just like the Indian brand, which is again is good one, and maybe other brands. So the price is variable. It's different if it's there in your country or you are sending to get it. But it's if we're talking about the concept, it's the same concept of the stainless steel crowns, but in white. As we use the stainless steel crowns, we have the sizes, as Dr. Gooch was saying, we have the sizes, but you have to have the whole kit. You cannot manage going to general anesthesia without having the whole kit with you, because you should fit the proper size. And this is the investment. Having the whole kit is the investment part. But since you have it, you will sell the patient or provide the service with the amount of crowns that you're using. But having said so, if we're talking about prices, the average price, let's say, is $25 to $30 a piece. That's the average price of the zirconia crowns, as far as I know. And if you are making an anterior kit, so usually we use size from the central incisor, we use 4 sizes, which is according to New Smile, which I use, 0, 1, 2, 3. And this comes in right and left, so this makes 8 of them, and the same for the Bs. So we are talking about 16 crowns, and multiply with the price I'm telling you, so that's the price of a kit, an introductory kit. For example, we're saying examples. That's it. Next time when I come to Kenya, we will do a zirconia crown workshop.
Oh, great. Both hands-on and in theater.
Yes.
The question is, for cases that have been done under GA, is there an issue about loss of vertical dimension, especially when you're working on all 8 posterior teeth? How do you determine the vertical occlusal dimension, and how do you restore it if there's already a loss of vertical dimension?
That's a very good question as well, but we are blessed here. Before answering the question, we are blessed with the occlusion of the children. What do we mean with being blessed? Being blessed because the joint and the muscles and the periodontium are all forgiving for these children. And the very important result, one of the most important results that came from the very good quality research that came from the Hall technique, which is based on putting a crown without preparation. Again, for who doesn't know, the Hall technique is all about putting a stainless steel crown with no preparation. So usually it's a high crown. Yani the child, when he bites on it, he finds that this crown is high because, again, we did not prepare the tooth, just fixed the crown over the tooth with no preparation. So it's high. But according to the finite element analysis research and according to clinical research, what happens is that the crown or the tooth does have an intrusive action, and again, the joint and the muscles are always forgiving or with another clarification, it is adapting with that, so you can find that the occlusion is coming back to normal within anywhere between 2 to 3 weeks later. But this does not give me the chance or the green light just to get the child out of the theater with everything very high. I should try my very best to get the proper occlusion, and knowing that if I have some discrepancy, very small discrepancy that should be there, it will adapt automatically. So every effort should be done to get the proper occlusion. And remains the question, how do you do that? The most important thing before starting to work is to determine the vertical dimension by closing the teeth manually, because the child is sleeping, and be aware that sometimes the oral pack, which is a gauze that can be placed inside, can make you not comfortable doing this. So you should make sure that the pack is in place and the tongue is not interfering. And then you should, before, again, we didn't operate on the patient yet, you should take just like a screenshot in your mind about the pattern of occlusion. Close, and your reference points should be the canines, as we all do, even in the clinic when we do a stainless steel crown. So you should have an idea about the occlusion, and then start working and verify in each step. If you finished the right side, you should verify that when you bite manually while the patient is sleeping, as we did, again with no interference from the tongue or anything, you should establish the normal bite, or the least of 1 to 2 millimeters of height that can be adapted later, as we mentioned.
What's your opinion on the use of conscious sedation instead of GA?
Actually, conscious sedation is a very good option, and it has been there in the literature, and it has been used, but the problem is, when we're doing extensive treatment like this kind of treatment, rehab, as we're talking today, that's our topic today, we're talking about rehab. In this very young age, if you ask an anesthetist, he will be against doing this, because we have the risk of aspiration in this very young age. It's not with this amount of extensive work, which definitely under sedation won't be done in one session. It will be divided on some sessions, but again, why should I put this very young child with this extensive problems and this amount of big work under several times of sedation with the risk of aspiration and any other risks that should be there, provided that I have a very safe one-go treatment, again, very important, in the least possible time that is there, which is the general anesthesia. So for these cases, I prefer general anesthesia for sure because of these reasons.
Okay. Dr. Kubasu, thanks you for a great presentation. She comments that clearly referral to the pediatric dentist is very important. She does not do complex fillings or pulpotomies. She usually takes x-rays and then refers them to a pediatric dentist. However, she's asking, is Domicam, which is midazolam, is it an option for mild sedation in apprehensive children while doing minimally invasive caries lesions, or maybe quadrant therapy?
Actually, Dormicam, I personally used it previously. Dormicam is a good option as well. Usually it's taken oral, sometimes can be taken nasal. But the problem is, which I personally faced, that if we are doing minimal intervention, maybe it's good. But if we are using air water spray and we are using the handpiece, and I don't think that this is a good option. And one of the problems that I personally faced with Dormicam, that it sometimes turns into hyperactivity. it's not every time working properly, and if it's taken orally, it can also be highly affected with the amount of gastric filling. So if the child is there with an empty stomach, it's different when a child with a filled stomach. So it's depending on each case. So again, there is a risk of aspiration if I'm doing an extensive treatment. But again, as our colleague is asking, if we are doing a minimal intervention, maybe Dormicum is helping. We sometimes do a mixture of Dormicum and ketamine together as a nasal sedation before admitting the child to the OR. There is a paper that I was personally part of their authors that describes the technique, and the nasal sedation can be used before going to the theater for better separation from the parents and better experience for the child, not having the fear of going to the theater and so forth. So this is it's a pre-medication rather than being used as a sedation.
Is there a role of nitrous oxide sedation in the practice?
Actually, nitrous oxide, again, is a good option, but in Egypt in particular, if I'm talking about Egypt, we have it banned now for over 10 years. We had some problems during the manufacture of nitrous oxide, so they banned the use of the manufacturing, even the manufacturing and usage of nitrous oxide. This is in Egypt, but in different parts of the world, it's very good. But again, we have to know, as we all say, that nitrous oxide is not magical for everything. It's very good and it can be used, but at the end of the day, the child should have a minimal cooperation level to be able to benefit from using the nitrous oxide. It needs an anxious child mainly, but not uncooperative child, because if he is uncooperative, we won't be able to handle him with nitrous oxide.
With reference again to full mouth rehabilitation, is there a role of acrylic partial dentures in children?
Acrylic partial denture, or let's say PD dentures, because it's not a removable thing. We can use the PD dentures, which is acrylic teeth that are fixed with bands on the molars. And this is a very good option when we have no teeth, either avulsed or badly broken down, and I cannot help it or save it. But again, if I'm having a technique like the technique I've showed, and it's a reliable technique, and we can preserve the tooth inside the bone, again, we definitely should be able to think that the presence of the root with its osteogenic function, the natural osteogenic function, there is no research that is done to prove this so far. But again, if we imagined the presence of this root inside the bone as a natural thing, it's much better than just pulling these teeth out and replacing it with a partial denture, which has a lot of problems, either de-cemented or broken down, or having a part of the wire is out, or it has also a problem, some problems. But if it's manufactured properly, and sometimes, by the way, they can add zirconia crowns in replacing the teeth. If sometimes it is placed beside a zirconia crown that is there, so you can put a zirconia crown abutment on this partial denture or PD denture and do it. But anyways, the problem is not in the teeth, it's in the adaptation of the child to the denture by itself as an external object, and retaining it in place in terms of cementation and no fracture and no broken down and so on.
What's your protocol with regards to one-stage pulpectomy, especially like anterior teeth with abscesses or maybe with necrotic pulp? Do you face a challenge with one? Is the success rate different, or you don't have an issue with that?
Very good question. Actually, the success rate of pulpectomies is not related mainly to the number of visits that you do it on. It's mainly related, the success of pulpectomies is mainly related to the case selection. So if you properly selected the case, you won't have a problem with the number of times that you do the pulpectomy on. And just to let you know, we need to do a single step pulpectomy much more than having it on several times. Meaning that the number of cases that you will have to do pulpectomy on 2 or 3 visits is almost 3 to 5% from the cases that you need to do one go pulpectomy, either vital even or non-vital. So doing this under general anesthesia after properly selecting the cases is always a successful material, a successful treatment. And actually, there is a very big debate between cultures, different cultures of different treatment modalities, different schools of treatment, who see that pulpectomy firsthand is an improper treatment to do. Meaning that some schools till now in some developed countries see that doing pulpectomy is nonsense. And if things went to the point that you should do pulpectomy, extraction is a better option. So this is another point of view that we all respect, and we are obliged to do more research on that, and we are on that. We are doing research to prove this point. So again, it's not about the number of, the success is not linked 100% to the number of visits, either 1 visit or 2 visits or 3 visits. And this is proven by literature, by the way. If you went through the literature, you would find this. So in the general anesthesia session, proper case selection, and you finish it in one go, and you're happy with the results.
For the children who are very uncooperative, that do not have the benefit of a prior radiograph, do you ever take intraoperative radiographs to rule out resorption in chronically abscessed teeth in theater?
Definitely. This is one of the very important facilities that should be in the OR, because it's not routinely needed, but sometimes you need to have it. So intraoperative X-ray, periapical, just periapical X-ray is very important to be there in your facility, just to give you good vision on where are you standing and what is the treatment alternative. And again, as you mentioned, sometimes you cannot do preoperative, even panoramic or periapicals, because the high level of uncooperative children. So sometimes intraoperative X-ray, even for diagnosis or for visualizing where am I standing and where am I going during the treatment, is an important thing or facility to be there in the OR theater.
Okay. Oh, I think this is just a comment that having done all this treatment under GA, what happens when a dental abscess occurs in a 2-year-old after treatment under GA? This is the greatest fear of treatment of deciduous teeth. Do you have to go to theater again because of age and cooperation?
This is a very important question, and actually anything that we do is liable to failure. The only thing that is not really subjected to failure is the extraction. So again, anything has a pro and con. So when we decide to treat, to have the options or the benefits of the treatment, we should put into consideration and definitely inform the parents or the guardians about the possible outcomes. So Again, now, if I am fearing the failure, I will revert to extraction. And if I'm reverting to the extraction, I will dictate this concept on all teeth. And if I'm dictating this concept on all teeth, I will clear this mouth at this very young age. Because I can say to the parent, I will only extract the teeth with abscesses. And when I go to the OR and I start treating the teeth, I find some of them necrotic. So again, I will remember, I told him that the non-vital teeth should be pulled out. So I sit with myself and say, why didn't I extract this non-vital tooth? It's again non-vital. It's not abscessed yet, but who knows if I did the pulpectomy? So it's a challenge. It's an internal struggle. So again, if we decided to be in the safe side for good, you should clear this mouth. But from my personal experience of along the years, if you did proper case selection, you did the proper treatment in the best time, you will succeed. But your question is, nothing is guaranteed. So if you have failure, what will you do? This is a matter of a situation that will happen on that time. Sometimes if you are extracting, sometimes some sedation, but I prefer the sedation to be in an environment that at this very young age, that there is a support in it. Some sedation can do because it's just pulling a tooth out. There is no spray, there is no water, there is no risk of aspiration. So you can do some sedation and pull the tooth out if failure happened as you mentioned.
All right, thank you, Prof, for that enlightening presentation. I think now we will all appreciate the various factors to consider between evidence-based studies, dentist preference, and of course, patient needs. I think with that was the final question. I'd like to thank you again, Professor Osama. We're looking forward to hosting you once everything reopens. We were planning on a major conference, which probably will be postponed to next year in August.
Sure.
So we shall definitely invite you back.
Thank you, and happy to cooperate with you always. Thank you so much for everyone, and thank you for listening and being there for this time. Thank you so much.
Thank you, everyone, to all the students, the general dentists, and the pediatric dentists. Thank you for attending our KAPD webinar, and hopefully you'll have a good evening, and we shall see you next week for the next webinar on Thursday.
Thank you.